Hello, everyone. This session is ready to begin. Maria de Jesus Díaz-Pérez from the Center for Improving Value in Healthcare, or CIVHC in Colorado, will moderate this session. Maria, you have the mic.
Thank you, Charles. Good afternoon, everyone. Thank you for joining the session, Improving and Expanding Analytics in Public Health. We have today with us 3 experts in the health data field. They are all experts in using claims data to improve, to inform policy and public health both. I would like to invite you to review their bios once you have access to all the information in your program. And I would invite you to review their bios and to review their organizations. They do great work. We'll do just a brief introduction here. And we will be having each of the presenters speaking for 15 minutes, about 15 minutes. We will hold all the questions to the end of the 3 presentations. However, you feel free to write your questions at the moment they come to your mind. We will be monitoring the question and answer box, and we will be covering all the questions when we are finished. I strongly encourage you to reach out to the participants, to the presenters, during today and during this next week also. That's the reason we are here. This is a conference and this is the opportunity to meet and to connect and to find new ways to explore and use and take advantage of of the data sets that we have access to. That's all I'm going to say now. Our first speaker is Robin Gelburd from Fair Health. She's the president and CEO of Fair Health, and I would leave the virtual floor to her.
Thank you so much, Maria. I'm delighted to share with you the many ways in which Fair Health shed light on public health issues. The data help uncover clinical and epidemiological trends, reveal disparities in treatment protocols, and examine demographic differences in the incidence of disease. The data also reveal where people are seeking treatment for care and can help isolate areas where access to care may be problematic. Next slide, please. To start, I thought it might be helpful to provide a brief overview of Fair Health's origins for those less familiar with our organization. We are a national 501c3 independent not-for-profit organization created over a decade ago to eliminate conflicts of interest in claims data and to bring fairness, transparency, and integrity to health insurance information. Toward that end, we maintain a data repository of healthcare claims that is informed by rigorous methodologies and algorithms reflected by statisticians and economists. And we fulfill our mission by using the data to create benchmark products and custom analytics that serve all stakeholders in the healthcare system. We also fulfill our mission by maintaining and continuing to refresh and enhance a free consumer website that not only shines light on cost information, but offers an educational platform to help contextualize that data. Next slide, please. Fair Health maintains the largest private claims collection in the country. We now have over 31 billion records, medical and dental combined, that gets updated on a monthly basis. In the aggregate, it represents the claims experience for 150 million covered lives around the country. Tens of millions of those lives are longitudinally trackable and provide a rich starting point for identified research and analysis. The data are then organized into 493 different geographic regions, which tend to track with the first 3 digits of a zip code to really provide granularity to the data offered. Next slide, please. The data are statistically significant in all 50 states, plus DC and the US territories. The data are received voluntarily from approximately 60 national and regional insurers and third-party administrators and reflect both fully insured and self-insured data. Once received, the claims are subjected to a comprehensive auditing and validation process. Next slide, please. Apart from our commercial data collection, we are certified by CMS as a national qualified entity and thus entrusted with the entire collection of Parts A, B, and D of the Medicare dataset dating back to 2013. That collection accounts for approximately 32 billion claims apart from our commercial data. I should note that the Medicare Advantage data is in our commercial repository, separate from the Kiwi data. Next slide, please. Because of the breadth of our data collection, coupled with our independence, many federal agencies and officials have reached out to CareHealth for assistance with various programs and initiatives. For example, we provide data to the Bureau of Labor Statistics to assist them with their development of monthly medical indices. We've been asked to provide data samplings to legislators working on surprise billing solutions. We also have served as the primary source for GAO studies on ambulance services and dental services. We also serve as an approved data source for MedPAC as they report to Congress. And among other things, we have provided data to a number of agencies on various public health issues, ranging from Lyme disease, sexually transmitted diseases, to the opioid crisis, and most recently to the current pandemic. I'll provide a high-level overview of those studies in a moment. Next slide, please. States have similarly turned to CareHealth to help advance their state initiatives and address public health issues of concern. For example, we serve as the official data source for many workers' comp fee schedules, surprise billing solutions, dispute resolution programs, as well as benchmarks for specialized programs that allow for state-supported services to crime victims, for example, or certain wellness programs. Next slide, please. Now let's turn to a few data extracts pertaining to different public health issues studied by CareHealth. Our goal is to offer actionable data cuts that allow the data users to advance policy discussions, design treatments, evaluate healthcare access and quality, identify clinical trends, study comorbidities, and track progress based on specific variables. Let's take a look at a sampling of work we did online. Next slide, please. Last year, CareHealth published a white paper on notable Lyme disease statistics in order to help fill the gaps in knowledge on tick-borne diseases and advance the work of other researchers. All of our white papers are offered at no cost on our website. This particular study helped the Subcommittee on Lyme disease and tick-borne diseases prepare a report to Congress as required under the 21st Century Cures Act. One way to help bring clarity to the incidence of disease is to striate the data by age and gender, since the public health impacts can be very different among the different age cohorts. Next slide, please. Given the longitudinal data we have, we are able to track patients who have been diagnosed with Lyme and identify common other diagnoses found in Lyme patients after the initial diagnosis. This type of analysis alerts healthcare professionals about possible testing for Lyme patients and helps plans evaluate claims associated with Lyme and potentially design benefits accordingly. This data also helps inform future research on Lyme-related disorders. For example, the data reveal that the diagnosis of general signs and symptoms, which includes malaise and fatigue, was more than 3 times more likely in Lyme patients as in all other patients. Next slide, please. At CareHealth, we sometimes feel that the data become like the canary in the coal mine, revealing public health trends and areas of concern before they become widely known, or alternatively, confirming studies regarding certain public health issues. Given that the rising rates of sexually transmitted disease diagnoses have garnered national attention over the past decade, we determined to examine the data to see what trends our data was showing. Next slide, please. Indeed, our data showed that between 2007 and 2018, claim lines with STD diagnoses as a percentage of all medical claim lines increased nationally 76%. The increase was greater in rural areas, 98%, compared with 77% in urban areas. Next slide, please. Given that our data include diagnostic codes as well as procedure codes, we can offer detailed views into the data that help propel analyses forward. For example, here we peeled back the data to uncover the top 4 increasing STT diagnoses from 2007 to 2018. You can see how increases in chlamydia vary dramatically from the increases seen in syphilis. Next slide, please. In the past decade, there has been widespread concern about evidence of a nationwide increase in behavioral health disorders, including both mental health and substance use disorders. Next slide, please. To shed light on behavioral health trends and patterns in this period, FairHealth analyzed 2007 to 2017 data and found that major depressive disorder was the most common diagnosis. Again, using the higher category of mental health diagnoses as a starting point for delving into more granular diagnoses helps data users answer more detailed questions. Next slide, please. This slide is from one of 4 separate white papers on the opioid epidemic we released, which led us to be invited to Washington, D.C. to meet with CMS officials and to present at the National Press Club. As shown in this chart, you can see that opioid dependence rose by over 3,200% between 2007 and 2014. A particularly alarming statistic arose from our data, which showed that claims associated with pregnancy drug dependence rose 511% from 2007 to 2014. Next slide, please. Here we sought to show that population size does not necessarily dictate incidence of opioid-related diagnoses. San Antonio, which census data showed represented only 5% of the state's population, accounted for over 66% of claim lines with opioid-related diagnoses in the period studied. Next slide, please. Our data also revealed wide variation in how states were addressing their respective opioid epidemics. This chart compares the top 5 most frequent procedures associated with the treatment of opioid abuse and dependence in 3 different states. As you can see, states are going in very different directions in terms of how they are treating this condition, which has significant public health implications. Next slide, please. As part of our ongoing work associated with the current pandemic, FairHealth studied the difference in the utilization of dental procedures between 2019 and 2020. Given the relationship between medical and dental health, substantial drops in dental utilization also have profound public health implications. Next slide, please. As you can see here, dental diagnostic procedures and preventive procedures have seen significant declines during the pandemic. Next slide, please. We also have been doing detailed studies of telehealth during the pandemic. Interestingly, in contrast to the in-office drop in dental visits, teledentistry has seen a steep increase, with March seeing an approximate 2,700% increase and April seeing a rise of 3,400%. Next slide, please. Let's look at just a few other examples of how we have provided transparency to various public health issues. I should note that we typically pair our data cuts with visualizations to help stakeholders digest the billions of claims we are distilling and examining. Next slide, please. Given how you hear more and more about severe food allergies, including deadly peanut allergies, we thought that the public would be well served by sharing with them findings from our ocean of claims. Our data demonstrated that although the majority of food allergy diagnoses occur in childhood, some of these allergies continue into adulthood, and food allergies can even emerge for the first time in adults. Next slide, please. Having 3 boys who are active in sports, this was a topic of particular interest to me. We gathered data and published an infographic on concussions in children and young adults. We found a 500% increase in concussion diagnoses since 2010 for those age groups. Next slide, please. To help shed light on the COVID-19 pandemic, we recently released an interactive monthly regional telehealth tracker, valued new codes recently codified by CMS and the AMA for specimen collection and testing, and have issued 4 widely disseminated studies on different aspects of the pandemic, all of which are available at no cost on our website. Next slide, please. For example, our regional telehealth tracker juxtaposes a month in 2020 with its corresponding month in 2019 to see how telehealth is changing in real time. As you can see in this slide, between April 2019 and 20, there was a shift in the types of diagnoses and the distributions of those conditions for which people sought telehealth services. Interestingly, hypertension was the 3rd most common diagnosis associated with individuals who sought telehealth treatment nationally in April 2020, despite being absent from the top 5 in April 2019. Next slide, please. In one of our COVID-19 briefs, we were able to estimate changes in hospital revenues by comparing 2020 to the same months in 2019 after a CPI adjustment. This slide speaks for itself. Next slide, please. In our 4th COVID-19 brief, Fair Health examined its longitudinal data on patients who had been hospitalized for COVID-19 to look for comorbidities that had been present at least 15 days prior to the initial diagnosis. As shown here, chronic kidney disease and kidney failure ranked the highest, with 13% of all hospitalized COVID-19 patients suffering from this condition. Next slide, please. In another COVID study, we analyzed the impact of the pandemic on healthcare professionals' utilization and revenue. Of all professional specialties, oral surgery had one of the largest decreases in both utilization and estimated allowed amounts. Next slide, please. Adult preventive care was not immune to the pandemic, as you can see here. We measured the change of preventive care visits, which are represented by CPT codes covering both new patient visits as well as established patient visits for individuals 18 years and older. In March and April, preventive care visits for adults fell substantially. Next slide, please. I want to thank you for your attention, and I look forward to hearing from the other panelists on this virtual panel. Thank you.
Thank you, Robin. And I'm going to introduce our second speaker. Just a reminder, if you have questions during the presentation, please write them in the Q&A box, and we will be monitoring the box and get all your questions answered at the end. Now with you is going to be Pamela Mink, and she is the Director of Health Services Research in the Health Economics Program at the Minnesota Department of Health. Pamela?
Thank you, and thank you for the opportunity to present to everybody today. I'm glad to be here. Next slide, please. So this work has been led by my colleagues at the Minnesota Department of Health who work in the Health Promotion and Chronic Disease Division. So just wanted to acknowledge especially Jim Peacock and Emily Stiles, who really have taken the lead on this work, but I'm happy to have the opportunity to present it to you. Next slide, please. So I'm going to talk about 3 related projects about hypertension, prevalence, and medication treatment in Minnesota. All of these analyses use the Minnesota All-Payer Claims database, and then I'll talk a little bit about how this has contributed to addressing public health goals for high blood pressure or hypertension in Minnesota. So the first project is really just looking, kind of a survey look at hypertension prevalence in Minnesota. And we have a report that's up on our website and a supplement related to that. Next, I'll talk about blood pressure medication adherence. And that work has been put on a public health dashboard and a forthcoming report that's still in progress. And then finally, an intervention with pharmacists to help promote medication therapy management for patients with hypertension. And so I'll share with you the tool that was developed to use as part of the outreach with pharmacists. Next slide, please. And next slide. Thank you. So this is the first report on hypertension prevalence in Minnesota. And one of the main goals of this, what we really wanted to be able to do, was to present and share data in a way that would be useful to local public health and healthcare as they address hypertension in their communities. So by seeing their own data, whether it's on the county level or at the zip code level, that they can use that to tailor interventions to the populations that they serve. Next slide, please. So the data shown here are included in the supplement to the report, and there's one file that is showing hypertension at the county level, and then the other showing it for each zip code in Minnesota. And the data then for each of these include the number of adult Minnesotans with hypertension, the age-adjusted hypertension prevalence, and then shows hypertension prevalence by 3 age groups, and then by 4 broad payer groups. Next slide. And so here are a couple of maps from the report, just to give you a flavor of the report. So in the figure on the left showing the state of Minnesota, the lowest levels of hypertension were seen in counties along the corridor from St. Cloud to the Twin Cities and then down to Rochester. And then the highest prevalence was in Northwest Minnesota, and this is true across all of the age and insurance groups. And in the supplement, there are separate maps for these different groups where you can see that as well. And then the figure on the right shows the 7-county Twin Cities metro area, and particularly in Hennepin County in Minnesota and parts of Ramsey County where St. Paul is, there was a lot of variation really across short mileage differences. So in Minneapolis, in North Minneapolis, you see one of the darkest shaded areas, which shows high hypertension prevalence. And then nearby, just about 3 miles away, you have some lighter shaded areas in Southwest Hennepin County and Southwest Minneapolis. Next slide, please. And then this is another presentation that shows the counties in Minnesota that have 10,000 or more adults with hypertension. Next slide, please. So I want to talk a little bit about some of the features of an APCD that really lent itself well to producing this kind of a report. So many of you or most of you are probably also familiar with the behavioral risk factor surveillance system, and both that approach and an APCD can provide information on prevalence of high blood pressure in Minnesota. One important distinction is that for BRFIS, it's based on self-report, so it's really been to be understood as a measurement of individuals' awareness that they have hypertension or high blood pressure, so they can self-report it. Whereas for an APCD, we rely on the diagnosis and the pharmacy codes to identify patients with hypertension. And that is really a measure of treated prevalence. So a subtle difference between the two. The study populations are also derived differently. For BRFIS, it's a sample of a small proportion of all Minnesotans, designed to be a representative sample so that you can make statements about the whole of Minnesota. For the APCD, at least up until 2016, we had over 90% of all insured Minnesotans. And that will continue to be virtually all recipients of Medicare, virtually all on Minnesota healthcare programs, which includes Medicaid. But starting in 2016, because of GOBE, we lose some of the commercial payers who've been withholding data. So it's the geographic granularity that's really the main advantage for the APCD, for the completeness of the data through 2015. And this is what really allowed us to show and share data at the zip code level and the county level for local public health and other partners. Next slide, please. So Project 1 provided the framework for moving on to Project 2, which was focused on medication adherence. Next slide, please. So existing blood pressure medications are really highly effective if taken in the right dose and taken at the right time. So in Project 2, we used the pharmacy claims data from the Minnesota APCD to measure blood pressure medication adherence. And we used to measure the proportion of days covered, which was developed by the Pharmacy Quality Alliance. So the data were used to populate the blood pressure medication adherence tab on the Department of Health's cardiovascular disease dashboard. And you can see that on the left, although you can't see the numbers very well. So it's close to 80% of Minnesota adults were adherent to their blood pressure medication. And then we have a forthcoming state report in progress that looks at non-adherence and broken down by age, sex, payer, and geography. Next slide, please. So just a preview for the forthcoming report on non-adherence is I'll show you a couple of these findings, and particularly because some of these lead into the third project. So on the left, you see the non-adherence across the state of Minnesota. So the areas with greater non-adherence are in northern Minnesota and in Minneapolis and St. Paul, with lower non-adherence, so higher adherence in southern Minnesota and particularly southeastern Minnesota. What you see on the right is that non-adherence really varies by age. And for young adults, 18 to 44 years of age, the non-adherence proportion is close to 50%. Next slide, please. And then when we looked at non-adherence by payer group, we found that Minnesotans who were covered by Medicaid had the highest percent of non-adherence, and again, right around 50%. Next slide. So preventing hypertension and controlling hypertension can really have long-lasting impacts on community health through improved heart health and improved brain health. So it's really important adhering to these medications. That said, this isn't just a measure or an indicator of compliance or non-compliance, because non-adherence can be a signal of side effects, that something's wrong in the dosing. So it's really one measure that, to be fully implemented, you really need to do outreach and have communication between a healthcare provider and a patient. Next, thanks. So in projects 1 and 2 in the reports, or for project 2, the draft report, there's a section on recommendations for individuals, for healthcare providers, for pharmacists, for payers, and for communities about how they can all kind of do their part to help lower risk of hypertension, as well as to help support appropriate care and treatment of patients who have hypertension. The part for pharmacists I highlighted here because the intervention in Project 3 really focuses on this. So one of the things that pharmacists can do is to provide medication therapy management services to patients who are experiencing adherence challenges or side effects with their medication, or otherwise struggling to meet their blood pressure goals. So next slide, please. So medication therapy management, or MTM, was the topic of the third project. Next slide, please. So medication therapy management involves medication therapy review and medication-related planning that can be done with a pharmacist. And in some of the other research we've done, it seems to improve both adherence and also other health outcomes related to high blood pressure, such as emergency department visits, inpatient stays, and length of hospital stay. MTM provided by a pharmacist is a covered benefit for Minnesotans who have Medicare, for the Minnesota healthcare programs, which include Medicaid and Minnesota Care, and then for certain commercial health plans. However, not all community pharmacies have been providing this service. So the main effort in Project 3 was to do outreach to the pharmacy managers and to show them what population they could reach and what the reimbursements would look like to them. And then I just have a note here that the eligibility criteria for Medicaid recipients for MTM have relaxed a bit. And so part of the outreach was to make sure pharmacists know that it's a greater pool of patients that they could, who would qualify for this benefit. Next slide, please. So there were a number of steps in doing this outreach and in developing this tool. So the main focus at the beginning was to create an information and a revenue tool. And I will show you a snapshot of that shortly. And then to take this tool to pharmacy managers of Minnesota pharmacy chains to share the information with them. And then with the downstream goals being to increase the provision of medication therapy management, to improve patient medication adherence, and then ultimately to improve the health of Minnesotans with hypertension. Next slide, please. So what we did, and again, this is based on some work that we did in projects 1 and 2, was to aggregate the counts of eligible patients at the zip code level and then assign them to primary care service areas and counties. And that's how the information would be shared with the pharmacists. So for the patient population that we focused on here, in part related to what the coverage guidelines are for MTM, and then also in part related to the patterns that we saw in reports 1 and 2. So we focused here on Minnesota healthcare programs, that's Medicaid and Minnesota Care. To be eligible for this to be covered by Medicaid, you had to have at least one other chronic condition. So we used the Johns Hopkins ACG system to identify both the hypertension cases and also the presence of another chronic condition. Focus on those who are non-adherent to their blood pressure medications based on that PDC measure I showed you previously, and that they had no previous claim for MTM. And then we estimated the revenues per MTM visit from the claims, which would really be a conservative estimate of all the patients who could benefit from MTM. Next slide, please. So here's the worksheet. It's basically an Excel spreadsheet, and I know you can't see it very well, but basically these are tailored for each pharmacy chain that was approached. It includes patients with hypertension who meet the eligibility criteria, non-adherent, in the PCSAs and counties that are part of the service area of the pharmacy chain, and then also provides information on what their closest store location is to each of these counties or service areas. It gives them the number of patients with hypertension, with poorly managed hypertension in their area, and then tells them, gives an estimate of the amount of revenue that would be generated by providing MTM visits to these patients, as well as the FTE that is thought to be needed. And so you see across here in the shaded vertical column, it's set as a default at 100%, but the pharmacists or the person doing the outreach can change that so that it's not quite so high. And so the worksheet was shared with, to date has been shared with 2 pharmacy chains and with plans to further share through existing collaborations. COVID has interrupted this work, but it has also contributed to this work in one positive way. So to begin with, one chain has since sought credentialing through the Minnesota Department of Human Services for their Minnesota Medicaid to be able to provide this service to Minnesota Medicaid patients. And as of June, they've credentialed 92 pharmacists with more underway. They've had, at this one chain, 2,000 patient encounters between April and June. And then incidentally, the work has been facilitated by COVID waivers that allow MTM services to be provided through telephone encounters. So the bottom line here is that pharmacists have discovered that there is a market for this, that they can better serve their patients, and that they can be reimbursed for this effort. And I won't rehash the summary here, but I'm happy to take questions today or in the future through email. So thank you for the time.
Thank you, Pam. That was great. We're going to move to our third presentation. The third presentation is going to be provided by Melanie Boyd. She is the Director of Analytics from Arkansas Foundation for Medical Care. Melanie, the floor is yours.
Thank you, Maria. Good afternoon, everyone. The title of this presentation is Bridging Substance Use Data Gaps. And the reason for that is the opioid problem is an incredibly fast-moving public health crisis. I know that's been the case nationally, and it's no different in Arkansas. Next slide, please. The frustration with tracking any health crisis is having enough data to do it effectively. And we identified several data gaps that I'm sure are familiar to the audience here. The first is outdated data, data silos, and data reporting issues. I'm going to go into each one of those briefly before I talk about the solution. Next slide, please. The first data gap, data silos. This is true in private sector, public sector. Each state department has their own data. They have got different data systems. Trying to share data is really difficult. You have to have DUAs, OMUs, all sorts of legal things to share data since this is PHI data. Next slide, please. One of the biggest problems that we had, it was outdated data. It's really hard to have actionable ways to respond to a crisis if you don't have the most current data. We were finding when we were pulling data, some of the data was 2, 3, maybe even 4 years behind. And so, by the time you're looking at data from 3 years ago, you're not really sure what is happening today. Next slide, please. Another issue that we were discovering was data reporting issues. There's 75 counties in Arkansas, which means there are 75 coroners. Some coroners were reporting into the MDI log, like everybody wants them to do, and some were not. I've heard tales of coroners with filing cabinets in their garage with paper files and things like that. Another data reporting issue we were seeing, it wasn't always exactly, I don't want to say true, but it wasn't exactly accurate. An overdose death may be reported, as a cardiac arrest, especially in a small county where everybody knows each other, and they don't exactly want it to be listed as an overdose death. Next slide, please. Okay, so one solution, and it's been a very good solution, and you'll see that in a moment, was our drug director was seeing the same things. He was working very closely with AFMC. We work on a number of different grants as evaluators, and we were saying the same things over and over. We have these data gaps, we have these problems, and he wanted actual data. So the drug director's office responded to a grant opportunity by DOJ and subbed with us. This grant we call it the Category 6 grant, but the technical reason for this grant was public safety and public health information sharing partnerships. So it was a perfect partnership. Next slide, please. So we started MOUs with several different agencies, the first being the Department of Health. The Department of Health, of course, has our PDMP data, overdose death data, EMS naloxone administration data, overdose data, and NAS data, to name a few. Next slide, please. Another important partner, Department of Human Services. Claims data is always very important to see, what is happening. Treatment center data, first responder data. Next slide, please. Another important partner, State Crime Lab and the Coroners Association, which I've mentioned before. They have overdose death data, and also they have the MDI log, it's hard to say, data, where the deaths are reported. Next slide, please. Our last partner I'll talk about is Hospital Association. Again, administrative claims data is very important. Inpatient discharge data, emergency room discharge data. Next slide, please. So once we started this grant in the first year, what was important was getting everyone on board, getting all our partners on board, getting MOUs in place so that we could share the data, and have one central repository for this data. And so, once we had all this data together, we were able to create, and I'm so sorry, my dog is barking. We were able to create a data dashboard. If you go to www.afmc.org/opioid, you will start on the landing page. This landing page kind of has an overview, if you will, of things people might want to know at a glance: related deaths from opioids, prescription rates for the state, how much naloxone has been deployed in the state. Next slide, please. Once you get to this site or this dashboard, there's several different tabs. And I'm not going to go through them all because there are many, but I'm going to go through a couple and then mention the others. And then I hope that, sometime this week after this presentation, you'll go out to the dashboard and kind of look around for yourself, because it's very interactive. It's hard to do that in a PDF, but it has the ability to zoom in and zoom out. You can hover over things to get more rates. But I'm going to try to do the best I can with PDF. The first tab I'm going to talk about national drug overdose deaths. And while this was kind of important to the drug director's office, as well as anyone that's interested in prevention or treatment, you can kind of tell where Arkansas ranks nationally. How do we compare with the rest of the United States? You can't really see it. It's kind of hard to see, but if you zoom in, you can kind of see that you can hover over a state and see what their drug overdose death rate is per 100,000 people. Next slide, please. Another tab is Arkansas-related death rates. This is important because it outlines all 75 counties, and you can see the death rates by county. In the same way, you can hover over a county and see what that death rate is for the county. Next slide, please. Okay. Similar to the death rates, we wanted to compare Arkansas's prescription rates for opioids to the rest of the nation. And you can see here to the right, the bar graph, that Arkansas is pretty high up there. You can also see by the map that Arkansas is pretty dark red, and that's kind of not what you want to see. But it just kind of gives you an idea of where you are. Next slide, please. This is very important to us. Like I said, we work on a number of evaluation grants that support naloxone deployment. This way, we're able to chart how much naloxone has been deployed around the state, to kind of get an idea of how many drug overdoses were reversed. The neat thing about this one is you can click on the pie graph and just look at certain things. So, if you want to click on the administrator pie graph, you can see how much deployment was done by the fire department, the police department, ambulance. Similar for race, you can do by race. Source will tell you where the naloxone was funded, which grant it was funded under, because like I said, we have several that are funding the naloxone. And then the outcome, which thankfully the biggest one is a reversal. If you look at that last pie chart there, you can click on that and see where all the reversals were. Or you can click on the smaller one and see, where it wasn't a reversal, unfortunately. Next slide, please. Another important graphic to the drug director's office or the drug drop-offs. We have at least 2 big drug take-back days, but we have standing take-back collection sites all over the state. And what's neat about this one is, again, you can zoom in to here and look at where the ones are near you. I've actually done this before, when you're wanting to take back, old prescriptions that you don't want to just throw away, or definitely not put down the sink. Next slide, please. Like I said, you can go to county level. Like, you can click on the county and then it will just light up your county. And then on the right side, you can see all the take back collection sites in that county. Next slide, please. And you can get into street level. It's not going to actually, Google map you there, but you can kind of get an idea of where you are. Like, this one is showing a Kroger on Highway 10 for those of you that are Arkansans. Next slide, please. Similar to what I just showed you are the treatment centers in Arkansas. So if you're looking for a treatment center in your county, you can go here, and it's really hard to see. The slide is small. But again, you can click on and off of different subgroups. Okay. Some of the other slides that I don't go over here, you can look for MDI log status, so you can see which counties the coroners are reporting in. There's also a tab for drug arrests, so you can tell, how many drug arrests have happened in your county. Buprenorphine practitioners. Those are just some of the other slides and other tabs, and we will be adding others as well. Next slide, please. Thank you for joining us today. Please feel free to contact me with any questions, especially if you go to the dashboard and look around and you just want to know anything about it. Hope everyone is well.
Thank you, Melanie. And thank you to all the presenters for such excellent information that you have shared with us. And we're going to move to the question and answer section of the session. And we have a question for Robin. And this is related to the data you presented around substance use disorders. And the question is, could the San Antonio result that shows that 60% of substance abuse disorder claims for opioids be a function of diagnostic coding, at least in part?
Well, certainly coding always plays a role. I should also mention that our data are organized by place of service, where the care was rendered. So it's not to say that that necessarily represents San Antonio residents per se. It's where people are seeking care in San Antonio. So if you peel the data further, it may be there are a number of drug testing sites in San Antonio that's becoming a magnet for the state. And that's what we always intend to do, is basically hand the baton to public health officials and researchers to take our data findings and peel it back further to see what's really behind, what's the narrative behind the data.
Thank you, Robin. And Andrea, please feel free to follow up in the chat if you have an additional question. The second question is actually a double second and third question also for Robin. The question is, and comment from John Freeman, he said, excellent presentation, Robin. What is the approximate lag on the type of data you show today? And the second is, have you noted marked recovery in volumes as has been reported recently by some researchers?
So the first question about the lag regarding the presentation today is difficult because, as you saw, what we tried to present was a potpourri or sort of a buffet of studies we have done, and they all are at different time periods. Some were as recently, as just months ago, some dated back, 2007 to 2014. In general, the lag in our repository in terms of the clay that we're working with is 1 month old. We get data 1 month, each month for the prior dates of service. So it's quite current and allows us in close to real time track different kinds of changes in utilization. So for example, our monthly telehealth tracker, which is interactive on our website, we just released our May data. It gives us a little bit of a month cushion to take in incurred but not reported and do some QA on that data. In terms of the second question, just refresh me, Maria, what was the second part of John's question?
Sure. Have you noted marked recovery in volumes?
Thank you, John, for that question. We have obviously, we are a mirror to the healthcare system writ large. So obviously we're seeing a dramatic decrease in claims because of the fact that so many elective non-emergent procedures have been stalled or held off. So we are currently evaluating that right now as we're looking to see how volumes are changing. And we are obviously going to reflect that in both, in our analytics and our benchmarks, make certain accommodations for what that drop off may be. But it's something we're watching very closely. And we'll have more when the pandemic, well, hopefully is more in the rear view mirror, when things start returning more to normal, we can give a better view as to what is behind us and how things have really increased once again and moved from telehealth to potentially re-engaging in office with professionals.
Thank you, Robin. We have another question, and this question is for Pam. Pam, your high rates of hypertension look to be in areas with Native American reservations. How do find that systemic inequalities have led? How do you find that systemic inequalities have led to high rates of hypertension?
Great, thank you. Thank you for the question. You're right that some of those rural areas, and particularly in parts of northern and western Minnesota, are in areas that have American Indian reservations. And in addition to that, the little map I showed you from the first project that showed a lot of variation within Minneapolis, just for over short distances, one of those areas is a predominantly Black and African American community in Minneapolis. And so we definitely see patterns related to race and ethnicity, and as well as in rural areas. Now, unfortunately for the APCD, we don't have rich enough data that we don't have data on race, ethnicity, and language. But as you notice, we can infer some things from the geographic patterns, and as well as understanding, that we saw the much higher rates among Minnesotans covered by Medicaid indicates as other socioeconomic factors. So yes, we know that American Indians and African Americans have higher hypertension. What we're hoping to accomplish through this project is that we're providing at least the geographically granular data that local public health and tribal health agencies can use and address in their communities. But I think it's also incumbent upon us as the state agency to support that those efforts as much as we can. So definitely there's a role of systemic inequalities, and particularly so in Minnesota, but can't totally drill down on particular race groups because of limitations in the data.
Thank you, Pam. Any other questions from you, members of the panel, to your fellow panelists? Okay, hearing none. I have a question for all of you. Actually, I'm happy to be here, like listening to all your presentations. I think this is a great example of how great data can be used to great purposes like public health, and we need it. And we are living in a time when it's highly evident how much we need it. But my question is that great data, we know is even better when it serves a purpose and it drives change. And for us, in order to do that, and I think that comes related to Pam's point just now, it's like we need to engage a variety of stakeholders. You describe very different projects, and in some it's much more evident that what you are doing exactly, but can you all tell us a little more about the process and the experience of engaging stakeholders to address the topics that you are visiting in your presentations? And just to be fair, could we start at the end? Can we start with you, Pam, Melanie, sorry, and then Pam, and then Robin?
Sure. I mean, the reason that this all came about is we knew that we needed actionable data to bring about any kind of change. Because if you're looking at data from 3 years ago, or you're only looking at part of the data, it doesn't help you a whole lot. And so the reasoning behind the project was to get, current actionable data and all of the data in one place, so that our stakeholders would be aware. And part of this that I did not go into is the drug director has his own dashboard page that has more granular data that we wouldn't put, of course, on a public page because of PHI. And so he's able to really look and see which counties have problems, so he can go to the governor's office if he needs to and say, hey, we've got a problem in Crawford County. So that's where we are actionably. We are in the second year of this grant, so we're really in the middle, in the meat of it. I think more of that will come in the third year. It took us the first year to get all our MLUs on board and get everybody to where they were feeding us data that we could put together. And now we're actually have all that data together, and we're adding to this dashboard as we get that. Just last week we got that 2020 data. We were like, wow, we have 2020 data. So that's kind of where we are. And so next year I can't wait to see the actions that come from it.
Thank you, Melanie. Pam.
Sure, thank you. So the purpose of the first two reports, and one hasn't been released yet, was really to make it available to local public health so that they could work with it. We released the first report the middle to end of November, and then 2 months later we're all reassigned to COVID activities. So I don't have a lot of information about feedback from local public health, but I think that it's important, again, that we follow up with them to say, to find out what about, was this useful to you? What was useful? What would make it more useful? How can we triangulate it with other sources of data to really, fill out the picture? And then, as I mentioned in our third project, that was the main outreach effort at this time, because it tied in with some other things that were going on. And definitely we know from the pharmacies that, yeah, they're taking action and they are credentialing people and they are providing these visits. So that a lot of, satisfaction that seems to be a good approach for that corner of hypertension and medication non-adherence that is being addressed. But it's a broad health problem, and, a lot of different angles to approach it from. So again, partnerships and follow-up and engagement.
Thank you, Pam. Robin.
Okay, sure. So because Spirit Health sits in the middle of the healthcare ecosystem, if you will, as a neutral player, we interact with all the different stakeholders, and they use our data in different ways. So for example, our opioid studies were used concretely by MedPAC to alert Congress to add more money to the Medicare budget, because we showed between 50 and 65 years of age a large cohort of substance use disorders, and they had to prepare to fund the treatment for that. Health plans use our data, staying with opioid for a moment, to see, once they saw what we were revealing in terms of the epidemic, they relaxed some of the pre-authorization requirements for entering into a treatment protocol, recognizing that if you miss that opportunity, when someone is ready to get treatment and you're waiting for them to get consent, you may lose that. So again, it fed into concrete ways in which to design plans. Hospitals use our data to understand how to maybe build out their health systems when they see more patients accessing telehealth or going to retail clinics or ambulatory surgery centers. They broaden the different participants in their healthcare system. Likewise, with sexually transmitted diseases and concussions, it alerts coaches and school health officials to be more cognizant of the fact that there are people that may be injured on the field, and they should be more scrutinizing in terms of who should be taken off the field, and be more attentive likewise to these other public health issues, whether it's in primary care screenings and so forth. So it's always rewarding to see the data not, fall like a tree in the forest and nobody hears.
Exactly.
And that all the stakeholders could go hiking on their paths that are relevant to them and use the data in ways that are meaningful.
Thank you, Robin. And unfortunately, we're out of time. We are right on the edge. And I thank you, everyone, for joining us today. I encourage you to reach out to the presenters and learn more about their wonderful projects. Thank you all in the name of the presenters and NADO organization. Good afternoon. Bye.
Thank you.
Oh, Charles?
Yeah, I'm actually just going to point to everybody real quick and let everyone know that the next session is that NASHP session. So we'll need to go to a different site, just a little bit of a heads up for everyone.
Oh,
and also a quick
good.
plug, there is a session survey too for this and every session in the lobby. You can find a link for this session. So just want to let folks know that.
Thank you.
Thank you. Thank you all. It was great.
Yeah.
Thank
Bye.
you.